We are back at HIMSS 2018 in Las Vegas, Nevada. This is David Harlow, and I'm here talking to Greg Church, president of 4Medica.
Hi, David.
Good afternoon, Greg. Nice to see you.
Nice to see you as well.
So, we're here in the middle of the HIMSSanity, as they say, and trying to get a few thoughts together on the good work that you are doing at 4Medica. What I hear about your work is that you're working on patient matching solutions, a sorely needed solution in this mixed up, crazy health IT world of ours. So tell me a little bit about what you're doing, how you're solving this problem, what part of the problem are you solving, and we'll take it from there.
Great. Everyone wants to get to data. Everyone wants more transparency of what's going on with the health status of a patient as the model is changing. Health plans want to be more proactive, but the data still seems to be a problem. We reside in multiple data silos, different EHRs, different medical record numbers. Matching your information up as it's coming in from these different sources becomes a challenge. And when you look at data, you want to look at data from a centric, longitudinal perspective. And when there's questions about, is this really, David Harlow, or is it David M. Harlow? You got to look at it. It may be a different patient with the same medical record number, which is the worst case scenario that's out there. So we've looked at how do you identify quickly, more in a real-time manner. A lot of the MPIs that have been out there were never able to score and do things in real time. It was batch. And then as more information would come in, it would basically put that data source out of date until they were able to rescore it, re-index it, and look for that new information. Our approach is more on the big data technology. I use Google as the example. Mm-hmm. Search engine technology allows you to quickly drill in, get to the information you need at the time when you need it. So we took that same approach with data matching and said, look at, is there a way that you can have multiple data sources coming in, but quickly be able to identify if data that resides in those data sources, create a unique identification number, and always be matching up against that. So we did. We figured that out. It's kind of our secret sauce. As a matter of fact, we were able to get this patented very early on. But as you go now to an HIE, to a health system, who really relies on clinically making sure they've got the visibility of the right patient, it's not only a clinical risk if you don't, but the downstream risk from a billing, from a financial perspective, you could actually be invoicing, billing on the wrong patient, on the wrong procedure, and that puts you at risk, from a contractual perspective.
Yeah. And then I get David M. Harlow's knee replacement records in my medical record, and then I'm told I can't look at my own medical record because it's going to be a HIPAA violation.
That's right.
You said this is now patented, so you've been working on this for a while, I got it.
Yeah, so real quick, we've been in the lab connectivity space for 20 years. We've built our own repository up to 40 million identities nationwide, and we started to realize we have to ensure that as we're matching up the tests and the test results, we have to get it back not only to the right patient, but to the right laboratory that represents that patient and to the right practice. So we started feeling the challenge of matching within our own environment. So we started talking to some of the other vendors, and I don't have to mention names, but there were some big players out there we were talking to, and we couldn't find anything that would scale to the size of our repository. So that's how we got started. We actually built it for our own internal use case, and then as we started to realize how important that matching process is, it was, wow, we're not the only one dealing with this issue. And there are now, with these state HIEs that are, 9 million, 10 million, 15 million states, as far as identifications, how are they doing this? And are they doing it effectively? So as we rolled this out early on, we would sit down with the state organization and ask a simple question. Do you know your identity duplication rate?
Nobody knew.
Nobody knew. So we started to realize maybe this is a bigger problem than we all realize. And so we started looking at data, and we started bringing in sample data, real data, and we started providing a match rate back to them to say, look, you're at 20%. You didn't know that. How are you feeling confident that you're using this data for reporting purposes, whether it's immunization registries, HIV registries? How are you that confident then if you don't know what you don't know? So that's where we started. That's where we got born in the MPI matching space. So, fast forward now, everybody's looking at how important data is, whether it's the opioid crisis, whether it's care coordination on chronic disease management. The confidence level rating still is not where it should be.
So for so many reasons. I mean, we shouldn't have to create arguments for why it's important to know who's the patient in the office at any given time. Yeah, many reasons. So another technology that people use at the point of care check-in is things like vein scanners, right? Sort of a unique identifier.
The
biometrics. Yeah. Do you see a point in time where within a certain geography or a certain provider footprint, you've done all the matching, all the historical matching that you can? Going forward, is there a better mousetrap? Is biometrics the way to go? Is there something else?
Yeah, that's a good question.
Is anybody else ever going to have a unique patient identifier?
Well, we're almost feeling like, because the government, they want to try to do something, but they haven't figured out how to do it. They've put these, challenges out there to figure out how to make, the global ID a reality. Mm-hmm. We believe the way we've set up our technology, and this is, not to pound our own chest, but we know we can scale to the 350 million plus and go beyond that. We believe without that global ID, true interoperability is not going to happen. We're in trouble. So today, and we'll take the opioid crisis, you've got somebody out on the street who's changing his or her identity frequently. They're coming into a hospital or to a facility. How does the person at registration or in the ER know this, right? How do they know that that person hasn't been into another facility, down the street, whether it's related to that system or not? If you had retinal biometrics or handprint, you could pretty much almost stop somebody in their track to say, hey, wait a minute, you're already in the database, but you showed up yesterday as Peter Harlow, not David Harlow. So I think biometrics has a huge play in helping to control that and to reduce, those people that are coming in off the street. So that's one use case. I think there will be other patterns with, machine learning and AI, where you can start to see geographically, we've got a problem in this area. We have a spike, of what's going on with level 2 narcotics being prescribed. Why is that? Is there a trend in the type of people? Are these people that now have learned they're migrating to other geographic areas? So we get excited about that. But again, one patient, one record, one identification, and you got to have an engine that can look at all those variables and put a higher weight. Here's an example. Phone number is probably a pretty consistent data attribute that you're not going to change frequently because you got to communicate, whether it's texting or a phone call. But you can change your address as much as you want because they don't want to know where you live, right? So names, date of birth, phone numbers can change frequently. But we realized this week here at HIMSS, put a higher weight factor on that phone number and get a tighter match, and now as that person's showing up in multiple data sources, and if you become the state HIE repository with a global ID, or if there is a global ID at the national level, guess what? Share that and be able to say, David's crossing state lines and doing all this stuff that he shouldn't be doing. Now we can capture you and we can share that. We can actually pass that identification over, whether it's to a hospital, a PDMP program. We're going bold with this.
All sorts of purposes and uses. Thank you. I've been talking with Greg Church of 4Medica. We're live at HIMSS 2018, connecting with you on Healthcare Now Radio.
Thank you, David.